Hello, everyone tuning in. Welcome to this program entitled The Next Wave in IgA Nephropathy. This is your guide to B cell developments at ASN Kidney Week. I'm Gaia Kopic. I'm delighted to be here with my esteemed colleague, Dr. Rich Lafayette. Welcome, Rich. Are you excited for ASN this week?
Yeah, I can't wait to get there. It's going to be a wonderful week following on wonderful years where we're entering this golden, if not platinum age of IgA nephropathy with so much pathophysiologic learning, so much drug development, and there'll be lots of new developments in Houston.
Yeah, I totally agree. This is such an exciting time. There's been so many updates that are happening in the field of IgA nephropathy. I think this year people are really looking forward to seeing what's going on in respect to B cell modulation. And those late breakers, I think, are going to show us a lot of new data coming out about those drugs. So just to kind of launch us off, Rich, can you remind us why we're so enthusiastic about targeting B cells in IgA nephropathy?
Yeah, for sure. As I mentioned, the last few years have been pretty much blockbuster because, as you know, we've really learned that patients with IgA nephropathy have a sort of rough road ahead. About half of them with ongoing proteinuria, any kidney dysfunction, would typically expect to be on dialysis within 10 years. And we have to do much better than that. These last few years, we have seen the development of targeted steroids. We have seen endothelin receptor antagonists, and we've seen our first complement blocker available to prescribe, at least in the United States. And those drugs do make a difference, but they don't typically get us to goal of getting the proteinuria as low as we can, certainly less than 500 milligrams a day, if not normal. And even more importantly, to try to get the kidney function to stay stable enough that the patient has a good shot of avoiding kidney failure their entire life. And again, it's been suggested we have to get back to the normal healthy population progression of less than 1 ml per minute per year to do that. So moving further into the pathophysiology of IgA nephropathy with B cell modulation sort of holds that promise, and it's really, really exciting.
Yeah, I totally agree. I think, even just a few years ago, the idea of achieving more of an immunologic remission in IgA nephropathy, in addition to our kind of constant goal of achieving a clinical remission, was something that was kind of the stuff of dreams. Even when you could do it on a short-term basis with prednisone, just the side effects really started to outweigh whatever benefit we might achieve. And then oftentimes you take away that immune modulatory activity and you would lose, some of the headway that you made. So this is kind of a whole new age and new opportunities for our patients. So I think we're looking for some some interesting, exciting data, both with the anti-APRIL alone and then anti-APRIL and BAFF inhibitors to be presented. So, what are some of the things that you're looking forward to seeing in some of these late breakers that we're expecting to look at?
Yeah, I think you're exactly right. Just to go back, I've been sort of harping for years against using corticosteroids or systemic immunosuppression for patients in IgA nephropathy because you're not even guaranteed to get a nice stabilization of proteinuria and GFR, although there are certainly patients who can respond. But as you said, it's at the risk of lots of side effects, and it's often temporary in nature, and then treating over and over again will only get long-term complications. So I think as we've looked back at the pathophysiology of IgA nephropathy, better understand how a genetic predisposition leads to high galactose deficient IgA1 levels, can lead to autoantibodies to that galactose deficient IgA, leading to immune complex. And of course, it's that immune complex that deposits in the glomerular mesangium, leading to inflammation, hematuria, proteinuria, and eventually progressive scar and kidney dysfunction. Looking at blocking those antibodies from ever being produced really is attractive. And in the past, we've tried to do that with B-cell directed therapy like rituximab, but it wasn't very, very effective. And it was nice that in the development of other immunologically active drugs for other diseases like lupus, they did find that blocking B-cell cytokines, like you mentioned, like BAFF, like APRIL, could lead to reductions in IgA. And then it turns out they do lead to beautiful reductions in galactose deficient IgA1. And it's expected, and there's mild proof that that can reduce the autoantibodies and the circulating immune complex. So, again, the pathophysiology makes a lot of sense. It's really exciting. And then, as you know, Gaia, the preliminary data across this B cell modification, both, as you said, for anti-BAFF and APRIL drugs, which usually work by taking advantage of the TACI receptor and sort of weaponizing it with a FC segment of an antibody, you can clear BAFF and APRIL really, really well. And across multiple programs like atacicept, povetacicept, telitacicept, we certainly have seen reduction in galactose-deficient IgA1 by more than 50%. And then associated with that, in the early programs, there's been really substantial reductions in proteinuria, hematuria, and the appearance for, in the case of atacicept, up to nearly 2 years, that you can actually stabilize GFR. And at the same time, with monoclonal antibodies to APRIL, like we've seen in sibeprenlimab and in zigakibart, it's really, really exciting that likewise you get this nice reduction in galactose-deficient IgA1, reduction of proteinuria and hematuria. That's very impressive. And there's data, again, in uncontrolled fashion without placebo, out long term for some of those agents, again showing stabilization of GFR better than we've ever seen with other drugs. And again, in both cases, a record of safety that's really, really exciting because it's scary when you're reducing the IgA, you're also reducing IgG, you're reducing IgM. But so far, the safety message has been pretty consistent that patients tolerate it well. We're not seeing serious infections. When it's placebo controlled, severe adverse events are looking pretty similar. So, as you suggested, this week's going to be really, really exciting because we're going to see further data in a number of interventions for IgA nephropathy. But this is when phase 3 data will get further defined for the B cell modulators. So, we'll have a plenary session with atacicept. On Thursday, we'll have late breakers with sibeprenlimab and with povetacicept. And again, the expectation is that there'll be extension of that really, really rich phase 2 and phase 3 data that we've already heard a little bit about, and that we'll be a little closer to having approved drugs in our war chest that we really can combat the IgA nephropathy with.
Yeah, I mean, that was such a great overview and positive message that I totally agree with. I think that, um, the the safety profile and the GFR stabilization are two of the things that I am the most excited about, and I think many nephrologists are. It's interesting how, we have not in our field embraced immune modulators that much in some of, our historical diseases. We work with hematology, for example, oftentimes to dose things
Mhm.
like rituximab and things like that. And so I think as we, not just in our kind of more specialized glomerular bubbles, but as we like bring these drugs out to the general community, being able to really stress kind of that safety signal will be so helpful, I think, for people's comfort levels. And then also the fact that these are drugs that patients can take at home, inject at home, where you don't have to worry about kind of the infusion center situation, which is multi-layered, that all of those things I think are so helpful also in terms of kind of getting these out there into general use. It really feels like it's kind of unmatched. A lot of times I think in glomerular disease, we look for drugs that are kind of better than what came before. And, as we've already talked about, it's true that we sort of had something before in systemic corticosteroids, but it's really, you can't compare the efficacy, the safety, or, the ease of use. And so, I think one big question that will come out of this year is going to be, how do we use these drugs in combination? What's the length, what's the duration of therapy? Um, I think sibeprenlimab is the only drug so far that's done kind of a washout to sort of try to get at, what happens after. And so I think that a lot of these questions will be sort of the next stage. But um, it's also just so helpful to know that if we do use them for longer term courses, which we probably will in the appropriate patient population, um, that we don't really, in most people, have to have major concerns. And monitoring has always seemed to be, across multiple drugs, BAF April or April alone seems to be pretty consistently well tolerated, which is really nice.
Yeah, I think that's a lot of good messages as well in terms of being very patient focused. It's going to be a big learning curve for nephrologists with all these new medications for IgA nephropathy. Again, at the same time, we've had this wonderful development of much better approaches just to generic chronic kidney disease. So we've got beyond the RAS inhibitors, we've got the SGLT2 inhibitors, GLP-1 agonists. We've got MRAs, which will probably make a big splash at this ASN as well. And it's just very, very exciting times. So nephrologists are learning to grapple with all that news. And then in um, these other rarer diseases like IgA nephropathy, you'll have multiple drugs, as we already mentioned, targeted steroids to get beyond some of the toxicity, endothelin receptor antagonists, and now these B cell modulators. As you said, they're not to be feared, they're to be embraced. And again, already in the preliminary phase 3 data, we've seen wonderful safety, major impacts on proteinuria, impacts on hematuria. We're going to learn more about that. In phase 2, we saw this wonderful stability of GFR. So patients really will be clamoring. And as you said, knowing for each individual patient, how to prioritize all these different choices, because likely we'll have our first approved drug in the B cell modulators by the end of November. And then there'll be more coming over the following year. And nephrologists will need to either embrace them well, understand all their choices, or get used to referring to glomerular disease centers of excellences, the parlance right now. And I think we can work together as a field to further our understanding of the disease, the real risks, the need to address it early and consistently, and of course, to get the message to our patients too, that there's this huge opportunity they need to be advocated for. They need to advocate themselves for safe, well-tolerated, effective medications, as you said, that will likely need to be given chronically because, as you said, sibeprenlimab did have some extension data where it looked like the galactose-deficient IgA came up, but proteinuria was stable over the short term. Atacicept, also the galactose-deficient IgA came up quickly after stopping it with some return to losing kidney function. So we'll learn more about that at these meetings, learn about future state, maybe with plasma cell monoclonal antibodies. There'll be other opportunities, but it's going to be all really exciting and a whole new world for each of us.
I mean, I think you and I are in sync with how excited and enthusiastic we are about what we're about to see at this conference. I think that also, like, everybody's going to be galvanized by all these new opportunities, but most of all, our patients are so excited about what's to come. So, for the audience, we just want to say thank you for attending. We hope that, our enthusiasm is infectious. We're sure that it is. Rish, I look forward to seeing you speak at ASN and connecting with everybody, and then, of course, learning everything that is to come in the field of IgA nephropathy.
Great spending time with you. Thanks so much.
Thanks.